as most of you know who are showing up, we have Dr. Marcelik here today talking about buprenorphine for pain, which is like one of my favorite topics. And so this should be tons of fun. He hasn't been here for a while, so happy to have him back. And further announcements. They're moving slow today. We must have a bad connection.
Alrighty, we have some great upcoming talks on the 24th. We have one on fetal alcohol syndrome being done by the Proof Alliance. October 8th, we're talking about approach to inpatient civil commitment. Dr. Charlie Resnicott is doing that presentation. And I'm super curious about that one because that is such a complex process that I feel like everybody's just so unsure about.
Well, it's something we all avoid getting involved in. You're like, we could do this, but no, don't.
Right?
Don't even try.
Yeah, and then we have a Kratom update on October 22nd. And then at the bottom of the screen, there are also other Echo series that are available going on in the state of Minnesota. So feel free to check those out as well.
All right. Remember, if you have questions, call us. No personal problems, please. For the most part, we get quite a few calls about different patient situations. We'd love to kind of help you if we can. So our phone numbers are there. Reach out to Aaron or myself, and we'll help guide you through.
And just remember that Stratus Health has the core website available, so don't reinvent the wheel. If you need a policy, protocol, or workflow, check this out first, and you might be able to gather some helpful resources.
And I bet that's it. All right. So what we will do is we'll have...
Kurt, just quickly, we want to do some Zoom polls before we move into the presentation. If Katie, if you have those ready, please.
Lucky you grabbed me, Senka.
Yep. Yeah, let's do just two Zoom polls really quick, painless.
All right, is everyone seeing those up on your screen? Thumbs up. All right, which of these best describes your role? We'll give you a couple seconds here, and then I think there's 2 in total. Right, Senka?
Yeah, just 2, yeah. Mm-hmm.
I suppose I should answer the question too. Why not?
Yeah, everybody is invited.
Do we have one more? There. Oh, that's the provider one.
Mm-hmm.
All right.
Very nice. And then the second question, Katie?
I have to back out and go.
Again, Katie, if you need any help, I'm right here with the technical stuff.
Well, now, okay, they make it kind of different here with the iEcho, how to get to the polls. Just 1 second.
Sure. If you can pull up the previous poll so we can just look at the results a little bit. It sounds like we have a really good mix of different disciplines represented today, so that's very good.
She's probably trying to pull up the next one.
I'll pull up the next one. Okay. Yeah.
I was going to say, here's the results, but yeah, I can't do them both at the same time, sadly.
Sure. No problem. No problem.
Okay. Sorry.
I think if we had video in her house, it'd be her daughter on the keyboard just Katie's trying to guide her.
Mm-hmm.
We can also do it later, Katie, so we can maybe move into the presentation and then do it again after the presentation. So if you're still looking for it.
There it goes. Pertaining to MOUD as a part of your role.
Oh, and by the way, we don't have the slide anymore that says, hey, feel free to turn on your video. We got a lot of people with their video on today, but man, Isaac would much rather talk to your face. So don't be afraid to throw it on. Even if you're eating, as long as it's not peanut butter. I hate peanut butter.
I did not know that.
Oh, I hate it.
Watch out if you're eating Swiss rolls. Kurt might show up at your house or at work.
Swiss rolls they're fortified.
Very nice. A lot of people working with MOUD patients. Okay, very nice.
Okay.
A few not applicable, but that's okay. All right, take it away, Kurt. Sorry for
Okay, so we have Dr. Marslick here today with us, and we'll let him introduce himself, tell us a little bit about what he does. He's given talks here before, although it's been a while. We're just so thankful he could come back and talk about buprenorphine for pain, which is like one of my favorite things to hear about and to talk about. So go ahead, Isaac, it's all you.
Great, thanks. I'm going to try to share here and see if we get this to work. How's it looking? Did it get into the right thing?
All systems go.
All right, thanks. So, as was mentioned, I'm Isaac Marsalic. I'm a physician at Health Partners. I've been there for about 12 years, and half my time is doing inpatient pain management at Regions Hospital, where we interface a lot with MOUD. And then my kind of other half is outpatient doing chronic pain management, a little bit of interventions, a lot of opioid management, among other things. And then I play in a tango orchestra. That's me down there playing guitar. If anybody wants to join the tango orchestra, now's the time. Our first practice is tonight for the new season. We run 3 seasons a year. You can have essentially no skill, a la me, and still join the orchestra if you want to do that. If you just remember one thing from the talk, it's probably think about the tango orchestra. Okay. So moving into the talk, we're just going to start with the assumption that, hey, we think opioids are right for our patient that we're thinking about when making these decisions, or they're already on it and we want to do something with buprenorphine. This isn't to talk about selecting patients necessarily for if they're appropriate for chronic opioids or not. There's get a lot of talks about that. That's an important thing, but I try to want to get this talk into more the nuts and bolts of what does it look like in the clinic when we're trying to get somebody onto buprenorphine and consider using it for pain. Okay. So buprenorphine is a really special opioid. And it works in a different ways. We at Health Partners just recently started a kind of CME where we're talking about buprenorphine for pain, kind of geared towards primary care. And this is one of the slides from that talk. And you can see we get some activation at the mu receptor. That's this guy here. And then we get some antagonism at delta and kappa. And because of this sort of different places that it works, we get different effects from it, different than full agonist opioids. And it's those different effects that make this a really useful medication when thinking about opioids and kind of chronic pain management. So why do we care? Safety is probably the biggest one. The much, much, much lower risk for respiratory depression. If we give a bunch of methadone or morphine or Dilaudid or hydrocodone to somebody, eventually they will stop breathing. If we give a bunch of buprenorphine, they'll probably keep breathing. I suppose we could probably get to a certain point, but the amount that we would have to give is so much to cause something like that. That there's just a lot of safety with it. There's also anti-hyperalgesic. So we know if people are on opioids for a longer amount of time, and especially if their doses get to be more, they start developing kind of widespread pain or more pain sensitivity. And buprenorphine doesn't have that same effect on people. There's reduction in the amount of immunosuppression. So people on opioids, they have immunosuppression. We don't have as much of that with buprenorphine. Less GI side effects. So in my personal experience, I do have some patients complain of GI stuff, especially with Suboxone, with the buprenorphine and naloxone. But especially the transdermal, I don't see that as much in some of the other formulations. And in general, it just is a lot easier for the GI track. People can be NPO and take it. These comes in patches. They come in dissolving tabs, dissolving films. And so you don't need to swallow anything to take the medication. So it's a nice option in that group. We can use this in renal failure and dialysis. It's often difficult to come up with medications that are safe and easy to use in patients with renal failure. The buprenorphine can be a really great option in this group. And then also, if we have somebody on opioids and we don't feel like that's safe or we want to do something different, there's a lot of studies that show that just stopping those opioids or rigidly tapering them off, especially quickly, can lead to really, really bad outcomes. And so this is where buprenorphine can be a really nice option as a bridge to complete a taper, or sometimes just to be on as an alternative, much safer option. And so this is an article that just came out last month. Dr. Farron is actually on the talk. I see Susan here. So Susan, whatever I get wrong, please make sure to correct me when I talk about your study. But this was our clinic here at Health Partners. Dr. Farron and a group of just really, really amazing clinicians worked with patients. And what they did is they had a group of patients not on any opioids and a group of patients on opioids, and they tapered or converted patients to buprenorphine and looked at how they did as far as their pain management. And probably one of the most astounding things is they followed patients for 4.5 years, and finding any study around opioids that goes out that long, I'm not aware of another study that follows outcomes that far. And it turns out that if you kind of do it right, which we'll talk about how I think that is, which is essentially a really patient-centered way of doing it, you get the exact same outcomes for pain management as if patients aren't on opioids at all when they come in. And so it was just I thought a really powerful kind of study that showed that you can really get people off opioids, or in some cases transitioned onto buprenorphine, and still have really great outcomes, as good as if they weren't on opioids at all, which sort of asks the questions, sort of, what is the role of opioids for these patients? I don't know, Susan, was there anything else you wanted to add about that? Oh, you think
no, that's good. Thanks, Isaac.
Great. All right, thanks. So how dangerous is this? And so this was just a study I found. They looked at all the opioid-related deaths in West Virginia over a 15-year period. 20 of the 8,000, 8,100 had just buprenorphine involved without any other drugs or anything else. And of those patients, 7 had very significant cardiopulmonary comorbidities that would kind of maybe contribute to this. And one of the really interesting things in this is that they didn't say the number, but they said many or most of the patients did not have a recent script for buprenorphine, even though it was in their system as a drug potentially related to their death. And so it sort of begs the question of, if they didn't have a script for it, where did they get it? What else was going on around that as well? And so this is an incredibly, incredibly low number of, when we talk about opioid-related deaths, how safe is buprenorphine? And this just gives some context for that. Does it work, right? If we're going to switch people onto it or start them onto it, does it work very well? And it turns out it does. For acute pain, lots of studies showing that it's at least as good as morphine. For chronic pain, 70% of people say that they think their pain is actually better controlled on buprenorphine relative to other opioids. We'll talk a little bit as we get into it. This is just a conversion that we use. And initially, we kind of had a much higher conversion of essentially 1 milligram of buprenorphine being about 75 milligrams of morphine. We've really switched to 1 milligram is about 30. And then and we'll talk about conversions in a bit and equivalency, because it's just a lot of hand waving. But the 600 micrograms of Belbuca, which is a specific type of buprenorphine, is about 1 milligram of Suboxone or Subutex or plain buprenorphine, and that's about 30. So essentially 1 milligram is 30. If you use that, that's good. If you want to get a little bit more into it, if you're specifically talking about Belbuca, it's probably a little bit less, equals 30. And again, we just really want to get in the ballpark. Oftentimes I'm going up higher on these doses because people just feel like they need more. And because of the safety, I feel okay with that. But it's just a place to get us started when talking about how do we switch patients. When we dose it for pain, unless it's the patch, usually we're doing twice a day, up to 4 times a day. That seems to work better. Lots of times in the kind of addiction world using buprenorphine, you might see once a day or twice a day dosing. And so usually we dose it a little bit more frequently. And everybody's a little different. And this is kind of part of the trick of doing this, is some people prefer a certain type of buprenorphine. So maybe the Suboxone, which has an naloxone in it, maybe without that. Maybe they prefer the transdermal patch. I have some patients who get really into the weeds about the brands, and it really is like, I need to have the Rhodes brand or this brand or that brand because the other one doesn't work for me. And I mostly just want something that works for them. And so as long as it's affordable, that's a big one, and they're tolerating it okay, the type of buprenorphine that we're on, don't get too caught up on that. So one question that we get a lot is, what about the naloxone? So in the medication Suboxone, there's two sort of medications, the buprenorphine and the naloxone. The naloxone's an antagonist, but when you take it by mouth, it has basically no clinical effect at all, okay? And so when you inject it, it becomes really active. And that's the whole purpose of this, is that if you were to crush this up, inject it, you would have the naloxone kind of prevent getting all that opioid at one time and sort of maybe be a deterrent to using it in that way. But it turns out you just get a delayed high. So there's actually some people who prefer this. So the naloxone lasts for about 30 minutes. If you inject it, it wears off, and then you get all the opioid and you get this delayed high. So there's actually reports about how people kind of prefer that way of doing it. And so that's kind of one of the things. The other thing is that the buprenorphine has such strong binding to the opioid receptor that it just really outcompetes the naloxone. And so when patients come and say, I don't want to take the Suboxone because the medication is going to block my ability to get other opioids if I need them, if I'm having an acute pain problem, it's actually the buprenorphine that causes that problem. The naloxone doesn't, especially if they're taking by mouth. It's not active really at all. And so it's really the buprenorphine and how tightly it binds to the receptors that really prevents kind of some of the other opioids from taking effect. That's the issue. So they are correct in that it blocks the receptors, but it's not the naloxone that's doing it. It's the buprenorphine, and it doesn't matter the formulation. And so that often gets confused, like I was saying. Although Suboxone and Subutex are kind of promoted as drugs to help with addiction, the molecule in there is the same, the buprenorphine, and it's going to have the same effect. And so if I call it Suboxone, I call it Subutex, if I call it Belbuca, if I call it Butrans, if I call it peanut butter sandwich for Kurt, the molecule does the same thing. And so when we're talking about getting people onto medications, I don't have any concerns about using Suboxone or Subutex as a potential option to help with pain management, because it's just buprenorphine regardless of what we call it. We'll talk about some of the issues around stigma about being on those medications, which I think is a really big problem. And I think that's an important thing to address with the patients. But as far as what preparation to choose, again, I'm not getting too concerned about that. As long as we kind of have the dosing appropriate, it financially works for the patient, et cetera. So as far as this part goes, the bottom line, just don't worry about the naloxone, okay? It's not something to worry about, except to educate your patients about what's going on with it, which is it doesn't do anything if it's taken orally, okay? So side effects, this is kind of the same as most other opioids. The kind of dental problems are one that people get worried about. And I have had a couple of patients that have had some real issues with their kind of dental health with being on it, and we had to come off of it. And so that can happen. But generally speaking, it's going to be really similar to other opioids as far as the adverse effects. A lot of people also get concerned about the QTC. That's something that's out there. And this just doesn't seem to be clinically meaningful. It's less than what happens with methadone. And there's a lot of kind of studies out there now that suggest that maybe methadone isn't really clinically meaningful as far as changes to the QTC. I don't personally check EKGs unless someone might be super high risk for arrhythmia or something like that. If someone's QTC is already super high, maybe you're picking something different. But I don't get very concerned about this. And if someone was having a high QTC, I would definitely be looking at other medications to stop before buprenorphine as something that would be impactful for that patient. So I'll just put that out there with the QTC. I talked about the opioid receptors as kind of a slide that's probably shown up here at the echo a number of times. But to just give an idea, most of the time we're kind of dosing in this lower range, maybe up to 8 milligrams. I go up to 16. I know in the addiction world, we might go 24 or 32, but for pain management, I'm probably in this range the most, from 8 and below. And so even at 8, 75% of the receptors are taken up. We still have 25% of the opioid receptors available for other opioids if that person needed them for an acute pain problem. And so this can be helpful to talk to patients about that. Yes, the buprenorphine does occupy those receptors, but there's still some available to get benefit with. Precipitated withdrawal is another big concern people have when using buprenorphine. And essentially, buprenorphine, again, just really binds tightly to the receptor, so much so that it's going to kick off any other opioid that's on there. I should probably update this to fentanyl. We had one person who had used heroin like within the last 6 months, and we were all shocked that they came back positive for heroin because we just never, ever see it anymore. It's always fentanyl. So, but anyway, put any opioid you want in here, fentanyl, Dilaudid, oxycodone. Buprenorphine is going to kick that off. So if you have a bunch of receptors with a bunch of other opioid on it, you take buprenorphine, it'll displace that, and that can lead to a withdrawal, and they call it a precipitated withdrawal, the withdrawal that happens from taking the buprenorphine. It turns out that is probably a lot less likely than what we initially thought. This was a huge concern when people first started the medication, when it was first coming out and we first started using it. And we have just gotten more and more and more aggressive with getting patients onto buprenorphine without much concern for precipitated withdrawal. So this is a big study at a few different ERs, like 1,200 patients who had been using fentanyl. And then were transitioned onto buprenorphine. They come into the ER. They had used fentanyl prior to coming into the ER. And depending on kind of some different factors, they either got like 4 milligrams or 12 milligrams of buprenorphine as an induction, and less than 1% of them had precipitated withdrawal. Those are much bigger doses than what we're typically going to be starting patients out with in the pain management world. And so the likelihood of precipitated withdrawal in the sort of most of the pain management patients that we're taking care of, either, especially obviously if we're starting someone who's opioid naive, that's not an issue. But if they're on chronic opioids, those doses are going to be a lot less than taking illicit fentanyl. And so the risk, I think, is incredibly, incredibly low with the precipitated withdrawal. I'll say that with the caveat that if someone has ever had precipitated withdrawal, let's say they were on fentanyl and they took buprenorphine on the street or something, or it happened, or they think they had precipitated withdrawal from buprenorphine, it'll be incredibly difficult to convince them to try it again. Withdrawal is horrible, and people are very, 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 very reluctant to go back and do that. So you might be able, with some time and some trust, to kind of convince them that you can do it in a way that won't lead to precipitated withdrawal. But my experience has been is that it is an incredibly, incredibly difficult thing to try to convince people once they've been through that. So just FYI on that. So what are the options? So buprenorphine comes in a patch, a Butrans patch. You can see here, you can place it, you kind of got 8 different spots, both sides for the different areas here. 5 up to 20, and kind of the UK, they go up to 70, which I wish sometimes we had more options like that, because I think some patients would benefit. But we usually say that the 5 patch is equal to somewhere around maybe 10 MMEs as far as kind of coming with conversions. And the irritation of the skin is by far the most common side effect with the patch. And we'll talk about that in a little bit. Belbuca is a buccal film. It goes in the cheek, and it has a really kind of nice wide dosing range, 75 up to 900, usually twice a day. Sometimes insurance will cover 3 times a day, not often. And again, we talked about maybe 600 of this is equal to 30 morphine milliequivalents. This is typically the hardest one to get approved through insurance, or if it is approved, it's usually the most expensive. I will say for all of this, though, it has been easier and easier and easier to get these medications approved, or at least to be affordable for patients. And so if someone had a problem, a number of years ago because it was too expensive, it may be worth trying again and seeing how that goes, because it hasn't been as much of a barrier as it was 5-10 years ago. Subutex is plain buprenorphine. This is the sublingual tablet. It dissolves usually 2 and 8 milligram doses. These can be divided, but it is challenging because they're the dissolving tablet. They break into chunks. And so oftentimes I'll have patients say, I tried to split it in half. I get one half and the rest is just a bunch of shards of the pill. And so it can be a little bit tricky to do that. So ideally, you don't do the breaking of the tablets if you can avoid it with it. Like I said, it can be done, but it tends to get a little messy. Suboxone, we talked a fair amount about that. That's the sublingual tab or the film. And it comes in a few different varieties. These doses, usually the 8 to 12. We're not getting into that too much in pain management, though you might, I suppose. The films can be cut, and that's a little bit easier. But especially in your elderly patients, if they have arthritis, they're pretty small, and it can be just logistically challenging to do that. And so ideally, again, if you can avoid having to cut the films or the tablets, that's best. But sometimes the way the dosing works out, or the cost is just way cheaper to get an 8 milligram than something different, then you're maybe trying to cut it to make it work. Just an important thing when we're talking about these conversions, the MMEs, we often will conflate MMEs with safety. And the MMEs are the morphine milliequivalents. It's a way of kind of talking about opioids so that we can compare one to another to determine different properties about it. It was really developed as a way to say, how much pain relief does one get versus the other, and what sort of pain relief could you expect? And as we went through the opioid epidemic, we really conflated that with safety. And the safety is kind of related to the MME, but like with buprenorphine, it's just completely different. If I have somebody on, 200 milliequivalents of buprenorphine, 200 milligram equivalent of buprenorphine, I feel a lot safer about that than I do if someone's on that same amount of oxycodone or morphine, because of all the safety with the buprenorphine. So as we're talking about this and we're kind of going through and talking about these calculations, I just think that's a really important thing to keep in mind. And the data for calculating the morphine milliequivalents is just horrendous. It's just a lot of not great data, and a lot of sort of, you're trying to compare someone's pain and they say that's a 7 and someone else says it's a 7. You say, okay, well, that's probably about the same. And so it's just a way to get us into the ballpark of where do we start, kind of the medications, and where do we go to. So just some thoughts about that. So I'm going to kind of get into now more of the clinical stuff about this. And one of the things that often happens is we run into resistance. We have resistance when we're talking to our patients about trying to make a change. And this is just a very normal human characteristic. We all want to believe we're good at making decisions for ourselves, that we kind of know what's best for ourselves. And if someone says, hey, we should change something different, we're always a little bit resistant. If you have kids, you know this. If you work with other people, you know this, right? This is just a way that humans are designed. And so what we want to do is understand that, so that one, we don't get frustrated when our patients say, no, I don't want to do that. And two, be able to work with that so that we can move forward to hopefully something that works better and is safer for the patient. So some of the really common things that come up is I tried it before and it didn't work, right? That's a really big one that happens if you've had a patient who tried it before and it didn't work. You might have, I had bad side effects with it before, okay? And so I don't want to do it again. Or he says, my friend says I won't be able to get any pain relief if I really need it, if I'm on that medication. He's like, yeah, that's right. And then the last one's to be like, people think I'm a drug addict if I'm on the buprenorphine. And so, yeah, what we want to do is join the resistance. That's the first step. And then we want to ask a bunch of questions about that. So joining the resistance is just sort of like, I tried buprenorphine and it didn't work. Oh my gosh, I bet that was really hard. I hate it when I take a medication and it doesn't help me feel better. And you have to go through all that work to get it, and the insurance and the pharmacy, and then for it to not work. That really sucks. What happened with that? Oh, well, I was taking it and it was working actually, but I just couldn't afford it anymore. Oh, okay. Well, that's a whole different thing than what we're talking about. Or, yeah, I started on the patch and then I just didn't follow up with the doctor anymore because it wasn't helping. Oh, well, it sounds like your dose was pretty low for what you were on already. Maybe we could try something different, right? So we want to get to sort of more about that. But the first step is saying, yeah, that would really suck if that medication didn't work. And now we have an in to talk about what actually happened. Same thing here. Oh yeah, I hate it when I have medications give me bad side effects. I wouldn't want to try something again if it gave me bad side effects. What happened? I put the patch on and I had a horrible rash with it. And so I'm not doing that again. Oh man, I get that. We have actually a lot of ways to take care of that. And so maybe we could talk about how that could work better. Or this comes in different formulations. We could try a different type of buprenorphine for you that wouldn't cause that skin irritation for you. Yeah, we got our guys here. And so we talked a little bit already about the receptor thing, or yeah, I get it. I would want to make sure I could get good pain relief if I was needing it, if I had had a surgery or something like that. We do this all the time at the hospital, and we get really good outcomes for our patients. And the trick is that we have to be more aggressive with their pain management when it comes to that. And so there are receptors open, even if you're on this new medication, but usually we have to be a little bit more aggressive because you're right. That medication does kind of block some of those receptors from working, but there's still plenty available and we can do more to help you feel better. And this one's maybe the hardest one, I think, because I do think there's a lot of stigma. If someone gets put on Suboxone or put on Subutex, even if it's for pain management, that can be tricky. Not only potentially friends and family if they know that they're on that, but like they go into the ER or interact with other healthcare providers. And so I always say, yeah, that's probably one of the most difficult things. We're getting a lot better about that. And I know that it's not a problem for you, and you know it's not a problem for you. And I'll be here to help you as we kind of go through this. And I think at least at, our ER and our hospital, we do a really good job of taking care of patients who are on this medication, regardless of why they're taking it. But I think that is a real concern, and I think it really does happen both in our communities and in our healthcare systems when patients are on, in particular, the Suboxone and Subutex. So we talked about that. Okay, yes. So how do we start talking about ways to help people kind of think about the medication and get them to consider making the change? And I think most importantly, it needs to be a patient-centered conversation. If the conversation doesn't resonate with the patient or affect them at all, they're not going to be interested in making the change. So I often say, I want to be more aggressive with your pain management. And because the buprenorphine has a lot of safety, we can go up on your amount of opioid that you get. And this is very true. Most of the time, the kind of MMEs, and we talked about some of the issues with that, the MMEs are going to be higher when they're on the buprenorphine, and because it's safe, it is. So most people, if they're on opioids and they want to stay on opioids, and you say, hey, we can give you more opioids, that usually goes over pretty well, or at least it makes them interested in learning more about what's going on. I say we can get you on this without going through withdrawal. If they have concerns about that, we talk about how we're going to do that and make sure that we're going to do it in a way that doesn't cause withdrawal. I tell them that most people find their pains either the same or a lot better, and they're on a lot safer medication. And this is another one that I often say is if it doesn't work, because a lot of people, well, when this doesn't work, what are we going to do? Right? That's always the thing that people say. And I say, well, I think it has a good chance of working. We got a lot of things we can try. But usually I also say, but I don't recommend continuing what you're doing. And so I usually if someone comes in and they're on chronic opioids and I think that we need to make this change, I say, I'll give you the option. We can try the buprenorphine or we can do a slow taper. Regardless of which option you choose, we'll work doing a bunch of other things to help manage your pain. But I usually set it up like that. And usually I give them some time to think about it too if they need to. But I don't say, gosh, let's just see how it goes and then we'll go back to doing this thing. Or if it doesn't work, we'll go back and do your old regimen. Now, have I gone back and done someone's old regimen after going through and trying buprenorphine and stuff? I have a couple of patients that has happened, but that's not sort of my plan when we start going. And that's just how I practice. You might practice a very different way, and that might really work for you to do something different, and that's okay. But that's what's worked for me. We'll get 24-hour coverage of your pain. Most people are on some short actings and they're counting down the hours until they can take their next one, or they feel like they have ups and downs, or I just time it so that I can have 2 good hours of pain relief when I get my pain medication. And I say, well, if we give you the patch, you get 24/7 pain relief. Or if you take the film or the tablet, those are 8 to 12 hours of coverage. I think we'll get a lot better coverage of your pain if we switch to buprenorphine. Another really big one is that I'm going to be around. So at some point, the patient's going to try to test the trust between you and them about can they trust you to listen to them and make sure that this works. So part of that trust is being available. And so if we're making a transition, I'll say, I'll be right here. I want you to give me an update in a week, or we'll set up a visit in a week or 3 days or whatever it needs to be so that they can have some check-ins, because I want to make sure this goes really well for you. And so there's going to be, especially if someone's on opioids and they're going to make this change to a new one, that's a really big change usually for people. And they want some reassurance that you're going to be there to do it. Everybody has had different experiences. Some of the experiences out in the pain community or with other providers or clinics has been something didn't go right and they were abandoned, or essentially felt like they were abandoned, and they want to know that you're going to be there for them. And so I always try to tell them, I will be there for you. Let's make sure we have some specific time where we're going to check in about this. And then depending on the patient, and again, in particular, how safe you think things are, sometimes I give them some time to think about it. So this sometimes can be a lot. And I say, hey, if you need some time, let's continue your hydrocodone or oxycodone for the next month. I'm happy to do that. And then when you check in a month, you can let me know which of these 2 options that you'd like to consider, or 2 months or whatever. I had a lady who just recently, she had a bunch of stuff scheduled over the summer, and she asked if we could check in back in September. And I said, yeah, that's no problem. And she was fairly shocked about that she got another 3 months of the medicine before having to check in again. And then she came in and she was just very appreciative that she had the time. And then she said, hey, I got a plan for how I want to switch to the buprenorphine. What do you think of this? And I said, that sounds great. And she's like, I can't believe that we can just do a plan like this. And I was like, yeah, if you have a plan that you think is going to work, we want to do that. And so giving the patient some options and some agency in this, I think, is a really crucial part of making it successful. And so if they need some more time to think about it, I think that can be a really good option. Sometimes patients won't follow up. They'll probably go find someplace else if they're not interested in kind of going through with the program that we have. And that's okay too. But I want to try to give them every chance to make a change that I think is going to get a better outcome for them. We talk about worsening pain, so the opioid-induced hyperalgesia. And most of the time, if patients have been on opioids for a long time, they will relate to this. They will kind of notice that, yeah, I've had to take more and I just feel kind of more pain all over. And we say, gosh, well, if we change to this one, I think you won't have that problem and it can improve. And I like to say that, yeah, rather than having your pain get worse, I'd really like to improve your pain, because that's why they're usually there, is to get better pain relief, at least where I'm at. And then, yeah, just more about think about how you'd like to do this. And so we're kind of putting the focus on this is what's going to happen versus is it an option to keep doing what I'm doing? And that's sort of the ways I get into that. And then always, I'm talking about all the other stuff. We're really lucky at our system that we have lots of things that aren't opioids to help manage pain. I imagine most places have, a lot of things to help patients manage pain. And so the opioids are just one small piece of the pain management puzzle, a really important piece that needs to be stable for patients to really engage in the other stuff. But I want to make sure that I'm letting them know, hey, we got a lot of other things we want to do, because I want to do everything to try to help you feel better. Things not to say are things that really aren't patient-centered or things that won't resonate with the patient. As soon as you bring up the government, I think you've lost the patient. If you say, well, the CDC says, or blah, 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 one, it's not true. And two, the patient doesn't care about that. They care about their experience and their pain. You start talking about MMEs. Oh man. I mean, I probably lost some of you when I started talking about MMEs, and that's why we're here. But you start talking to your patient about MMEs, I think you're really going to get into trouble with that. And then I'm not allowed to prescribe opioids. So if you have a DEA number, you are. And so, that maybe that is actually true for you, but for most people, you are allowed to prescribe. I think a better way, if you're not going to be the one who's doing the opioids, if you're going to send somebody out, is to say, I really want you to have success. I'd like for you to meet with blah, blah, blah pain clinic or blah, blah, blah person in your clinic that does buprenorphine or whoever, because I think they have a really good option for you to help you with your pain, and kind of set it up for success, and that there's some options and things to go forward with. Versus I'm not allowed, so you need to go see someone else. And so I think that's a better way to kind of do it. And especially if you're going to have any sort of longitudinal relationship with the patient, I just generally don't think lying to them is a great option. So do that. So we're not really talking about tapers today, but this kind of applies to that as well. But these kind of inductions, getting people onto buprenorphine, converting them over, and tapers can be done in lots of different ways. This is Rome down here, and there's lots of roads that lead to Rome. Just like we can do this in so many ways that can work. Probably the way that doesn't work is if you have some rigid program that doesn't take an account to what the patient needs, and just try to stick with that and sort of kind of bowl through it. That usually does not work well. And so I don't care usually how we get there. I want someone on the buprenorphine because I think it's safer and I think they'll have better pain control. And so if they have a plan that they think that's going to work for them, that's great. They offer something to you, you just go with that, because it's much more likely to be successful if they say, hey, could I stop my short acting first and stick with my long acting and then make the change, or vice versa, or my daughter's wedding's next month, could I start it after that because I'm concerned about making the change then, or whatever. Yes, of course. We want this to be successful for the patients. And then as stuff comes up, you need to be able to pause. If you're tapering someone, or you're in kind of a longer conversion onto the buprenorphine, then you need to pause it when stuff happens. And this is that trust thing. It's sort of like, hey, this is really hard for me. Are you going to listen to me and make this so it kind of can work better for me, or are you just going to kind of stick to the thing? And almost always there's a valid reason for wanting to stretch things out. Or pause it, or kind of change what the plan was, and then you just resume. And so usually I say, yeah, let's do that for this month, and then we'll get back on next month. I had one lady, she called in like every month wanting to continue with what was going on, and her life was very chaotic. And so I finally said, hey, we haven't made any changes for about 6 months. And during that 6 months, you came up with you had a lot of things that had come up and were bothering you. And that you had to deal with. And so I get that, but I really think we need to get back on track with the taper. And she was super open and okay with doing that, because we'd built up some currency with the relationship of me saying, hey, you can take time and do this thing. I'm here to support you. Now let's get back to kind of what we agreed to. And that works really well, I think. This is just to set up the process. I know we're kind of at time, and so I'll just try to go through these as best I can. And so this is just sort of a way to look at, how we might do this with the patients. So a couple of cases here. We got our old lady on a low amount of hydrocodone. I see this fairly often. They say, I'm not sure why I'm here. Why should I do this? And I say, gosh, it's safer to be on Bupe. It's longer acting. I think you'll have a better outcome with it. And I give her some time to think about it, or if she wants to switch, we just switch over to it. With this, pretty low risk, I think, and so I'm okay with a way to do it that way. The MMEs, if we take the 15 of hydrocodone, it's probably somewhere between, I point with my finger like you can see what I'm pointing at. It's probably somewhere between 15 and 22. We do 5 micrograms of about 10. 7.5 would probably put us closer to the amount of MMEs. And so I usually start lower, though, in my elderly patients, and then we got some room to go up. So how do we do it? She could take the last dose of hydrocodone at night and just put the patch on in the morning. She could just put the patch on and stop the hydrocodone later. 3 doses, 10 doses, 2 weeks, 5 weeks, doesn't matter. It doesn't matter when we start the buprenorphine and when we stop the hydrocodone. In this case, I don't think there's any risk for precipitated withdrawal. And she says, hey, it's not helping. And we say, great, that's no problem. Like we said, we got to up the dose, right? She's not having side effects. We're on a really low dose. Let's increase it. She says, doesn't stay on during my water aerobics. I don't know how many of my old ladies do the water aerobics and have problems with the patch. Some of them find some success with kind of the Tegaderm type thing, the transparent bandage, and that can kind of sometimes help on there. Or I get the rash. This is by far the most common thing, and it looks almost exactly like this. It's a perfect square of painful skin. And I usually use the Flonase. There's other options too, but it's essentially you squirt it on the site, you let it dry, and you put the patch on, and that steroid in the Flonase really helps decrease the skin irritation. Probably putting a steroid cream on first or something would really work well. I've had a lot of success with the Flonase or generic for that. That's been really nice because patients often will say, gosh, it's really helping, but the skin, I just can't tolerate it. All right, we'll get into the next one. We're almost done. We get more opioids, though, this time. So 30 twice a day of morphine and another 15 3 times a day. She's having some falls. She says it's fine, but I think my dose could really be higher because it's really not working that well. We can give you more opioid. You've come to the right place. We can get you more opioid than what you're getting, and it can be a lot safer. And in this case, I might be a little bit more insistent that we make the change because she's having the falls. I might be a little bit less likely to give her a lot of time to think about it because I'm pretty concerned about a broken hip or something worse with that. So again, the conversion, we got about 100-ish morphine equivalents there. We got our 600 to 30 or our 1 to 30. So we're probably looking at somewhere between 900 twice a day of the Belbuca or maybe 4 milligrams of the Subutex or Suboxone. So we could just stop all the morphine and just wait maybe 12 hours and then start the Bupe. It would be that simple. She takes her last dose at night. The next morning, maybe 12 hours, maybe the kind of middle of the day, she just starts our 900 twice a day or 1 milligram 4 times a day, and off we go. We could ever just stop the long acting and then continue the short acting for a while. Start the Belbuca, in this case, maybe again the 12 to 16, 24 hours after the last dose. And then after she's on the Belbuca, stop the short acting, or again, just continue it for a while and then stop it if she felt more comfortable with that and you felt comfortable with that. Or if you felt like there was more safety with it, you could do a much longer kind of induction where you start at a much lower dose and just gradually increase it over a few weeks. She stays on the morphine, and then I think I had her stopping here, but you could ever stay on it. And then once you get up to kind of your goal dose, then stop it. So you could just increase it, really slow would be 2 weeks. We probably would increase it every day if we were in the hospital. All of these would be options for getting her on there. But it can be, even with a fair amount of opioid, as much as the next day you're starting the buprenorphine with really very little time in between. I can't afford it, so we rotate to something different. I don't care for the films. We put her on pills. My pain isn't very well controlled. If she's tolerating it, I say we can go up on the dose. She might be someone that we get more to like the 8 milligram range if she's been on that for a long time. Final one, this is a lot of opioid. 30 of methadone 3 times a day, Dilaudid 40 milligrams a day. Hopefully you're not seeing a lot of patients like this in your practice. This would be tough. Still 8 out of 10 pain. I can't, just nothing helps. Probably opioid-induced hyperalgesia. That's a lot of medicine. This is actually a case, a hospice case, where they went up on the meds and then said, you no longer qualify for hospice, and then sent her to the clinic to get it sorted out. So how do we sort this out? Lots of MME. Okay, depending on your calculator, you're probably like at 600 here. Okay. And so we probably are going to be looking at around 16 milligrams of buprenorphine for this. Probably could go higher. That's where I usually end up at. And I think this gets at the kind of continuum between opioid use and opioid use disorder. I think there's a lot of patients that fit in this gray area where they don't necessarily meet all the criteria to qualify for opioid use disorder, but the opioid use is still somewhat problematic. And so this is a really great place for buprenorphine. So how we do it, this is how we did it. This was in the hospital, but frankly, it could have been done outpatient. We just kept her on everything, and we just every day increased her buprenorphine until day 7. We stopped it all. And then the next day increased it again. No withdrawal, no side effects, no problems getting on to the buprenorphine. In a week, we had her on something she could get outpatient. I don't know how many people prescribe 90 of methadone and 40 of oral Dilaudid outpatient, but we were having a hard time finding someone wanting to do that. Really easy to find someone to prescribe Suboxone 8 milligrams twice a day. And so this worked really slick for doing that. And this is kind of the micro induction. And so if someone's on a high amount, this would be kind of a ways to do that. Okay, I don't know if anybody recognized any of the photos in there, but if anybody knows, these are all children's authors. Does anybody know who this is? I can't see the chat, so someone might have to call it out.
Are you asking about the female?
Yes, at the top left. Yeah. This is Lois Lowry. If anybody's read The Giver or Number the Stars, she also wrote The Willoughbys. That was my kid's favorite book. How about this guy down here? Anybody know who that is? I'm like the biggest kids book author nerd, I guess.
Is it Shell? Oh, Roald Dahl.
Roald Dahl. Yep. Yeah. So Roald Dahl, Charlie and the Chocolate Factory, James and the Giant Peach, Matilda. That's a big one. How about this scrumpy guy up here?
Gary Paulson.
Yes. That's Gary Paulson. He wrote Hatchet and a number of other books. He actually lived about 15 miles from my house when I was growing up. I didn't know it at the time, but a lot of great books about the North Woods. And I would be surprised if anybody knows these two characters down here. This is John Clausen and Mac Barnett. So they do a bunch of picture books together and won a bunch of awards. Mac Barnett is the Library of Congress's national ambassador for children's literature. And they have this great picture book newsletter that, of course, I am a part of. So anyway.
What's your favorite?
What's that?
What's your favorite?
Oh, so The Terrible Twos, Mac Barnett wrote that, and the Brixton Brothers are kind of the two series that we read a lot of, but all of his stuff is just full of heart and full of humor. It's really great. So anyway, okay, that's it.
All right, we have some time for questions. If people want to just unmute and ask or put them in the chat. I didn't look to see if there was some in the chat yet, Aaron.
I didn't see any.
Oh, and thanks for everybody for staying. I know we went over a little bit. I really appreciate you being here and listening to the talk.
Yeah, we still got a few minutes. One of the things that my questions, and I'm kind of in a niche because I do addiction, but yet I get patients from the pain clinic that they want me to switch over who've developed an opioid use disorder. And I think probably in this group, we probably have people who've had patients who developed an opioid use disorder from prescribed meds. And honestly, it feels like they end up needing more buprenorphine than I would expect. Mm-hmm. Is that something you've dealt with?
Yeah. And that's exactly right. And that's why I said I'm okay with going up higher, because almost always I end up needing to do that. If someone was on a fair, moderate amount of opioids for a long time, when I get them onto the buprenorphine, usually I end up getting into Subutex and Suboxone because we're going up on the dose. And as I've talked with other colleagues, that's really been their experience too.
I love that you included how to talk to patients and have the conversations. We get so many questions on like, how do you say this in a respectful and kind way? So that was really neat. And the case studies were wonderful.
Yeah, thanks. Yeah, I think that's probably the most important thing. It's a lot of kind of motivational interviewing type stuff. But if you can stay patient centered, it really makes the conversation different. And I'm always still surprised at how well the conversation goes, because when people start hearing like, oh, this might help with my pain, or I can get more medication, or I can get 24-hour coverage, those are the things that really resonate with them. And so now it's kind of gone away from don't take my meds away to, oh, is this really true? Does this work? And now we've sort of shifted the conversation to something more productive.
Something that Kurt has brought up several times that's always stuck with me is when he's meeting or gets referred a patient that's on a really high MME, he'll just put him at ease by saying, we're not going to change anything today. We're just going to have a conversation. So that always stuck with me. They're already anxious and super worried. So I think that's a good tip too.
Yeah. I in lots of places have where they won't prescribe on the first visit or something like that. And so like I said, there's a lot of different ways that you can do this. Generally, if someone is open to getting on buprenorphine, I don't want to miss that chance. And so I will do that on the first visit. But that it's a very reasonable way to say, hey, I want you to think about this and come back and we'll talk about it again.
Other questions from the group?
Thanks.
One of the interesting things is just like with opioids, we see people who overuse buprenorphine sometimes. It's just there's more is better, right? And in our clinic, being mostly an addiction clinic and a lot of mental health, often we'll see people overusing it. My first go-to is they're using it for anxiety, right? Because it does help. Do you see much overuse?
Yeah, I see some. Typically, it's patients that kind of overuse everything. They might not be using illicits, but it's like they're just sort of they use medications to kind of manage whatever things going on. Often times anxiety or other feelings. And so it's not just the buprenorphine necessarily. And so I do see some overuse, and I struggle with that a little bit because I feel like it's providing them some benefit, and I'm worried if I stop it, it's going to be like, this is all going to fall apart. And at the same time, we have a thing here where I say, hey, you should take it like this, and I need you to take it like that, because that's the deal we've worked out. It's sort of our relationship as me being your doctor and you being the patient. And so that is just personally for me, a struggle, because I sometimes think it's worse to try to take them off or switch them to something else, or are they going to get back on to full agonists? And then we're really going to be in more risk with that. But it's a challenge. Fortunately, it's not a lot of my patients, but I have had a couple. And then I'm kind of like, well, is this more opioid use disorder? Should we start thinking about Sublocade and just making sure that they're safe, or, and so we just start getting into some different areas with that.
Your segue was perfect there, because my next question was on Sublocade. And I in this clinic, in the addiction clinic, we have a lot of people are dual diagnosis, right? And my experience with Sublocade for chronic pain has been, wow, people really like it. What's your experience?
I have not had anybody that I've managed that's on Sublocade. They always end up in the addiction clinic. And so okay. I haven't had that. I've often thought of it as a really great option for patients. And in fact, some of my patients in particular, like, and I don't know as much about Sublocade as other ones, but some of my elderly patients, especially some with dementia that have a hard time remembering to take their meds, or it's kind of really convoluted regimens and stuff like that. I wonder if that might just be a lot easier. You just get your shot once a month, and then no one has to worry about did grandma overtake her, or hydrocodone or whatever else. But I don't know.
Yeah. Okay. Other questions for Isaac? I'm just looking. I don't see any other ones. Otherwise, we can let him go. That was a fabulous talk, Isaac. I really,
Thank you.
just really exactly what we needed. I thought that was a wonderful overview. And again, the cases were fabulous. So
Great. Well, thanks again for letting me do this, and maybe we'll see you again next time.
all right. Well, thanks again, and thanks everybody for coming. Anything else, Aaron? Anything we need to touch on before everybody goes?
I don't think so. Thank you so much.
Great. All right. Thank you.